Welcome to Real Talk in Medicine. My name is Shelley Vanker. This is a podcast production of UT Physicians. And joining us today for our very first episode is Dr. Steven Canfield, a urologist here with the practice plan. We're going to get things started with men's health. That's why you're the expert here. That patient population is often known for seeking out help far less than women, correct?
Yeah, this is true. Men are not great about their health care. I am a man, and I can attest that I'm not great about my own health care. So it's important that we advocate for men and encourage them to seek out the care, because we definitely have problems that we may or may not want to talk about as we get older.
Yeah, let's get things started with talking about prostate care. That's something specific that happens as men age, correct?
Mm-hmm. That's right. The prostate is an organ that all men have. It's involved in sexual function, and it sits deep in the pelvis. And so it's not something you see or maybe even know about. But because of its location and anatomy, it can have big effects on urinary function. It sits right at the outlet of the bladder. And it turns out that, like a few things in our bodies that continue to grow, like our hair, fingernails, prostate continues to grow in men as we get older, just when you thought you were all done growing. And so, about 80% of men will have enlargement of the prostate, or something we call BPH. And that is a word or a set of letters that men start to hear about as they get older and as they experience some of the common symptoms associated with kind of getting older as a man, like getting up at night to go to the bathroom more often. And there's all sorts of other symptoms that are part of that. As you can imagine, if you have something that's growing in the way of your bladder, it can get harder and harder to go to the bathroom. And if you're not emptying your bladder completely, you'll have to go more often. It also starts to cause problems in your bladder. It's kind of like your bladder starts to go to the gym every day. Every time it has to try to empty itself, it's fighting a resistance. And so resistance training will build muscles if that's what you're trying to do, but that's not great for your bladder.
No.
And your bladder builds up muscle, it builds up receptor sensitivities, and then that manifests decades later as constant feelings of having to go to the bathroom or strong urges. A lot of men will experience a sudden urge that's hard to get there. Women have these problems too, but in men it's often because of the prostate.
Okay. I want to back up really quickly. The acronym you used, BPH, what does that stand for?
Benign prostatic hypertrophy, and that just means non-cancerous growth of the prostate. And that's important because that often gets confused with cancerous growth of the prostate, which we can talk about in a little while. Yeah.
And so you broke down some of the symptoms for us. It sounds like it's constant feeling of urgency.
Mm-hmm, mm-hmm. There's a whole set of different symptoms that we think about as storage symptoms. So those would be coming from your bladder. Irritation and overactivity in your bladder can manifest as frequent need, urgency, and the words themselves that define these are really descriptive. So frequency, urgency, urge, incontinence, that's where it gets really bad. You can't make it. Hesitancy, hard to get started. Mm-hmm. Intermittency, feeling of incomplete emptying. And then the prostate itself being the source of a lot of these problems and getting too large causes obstructive symptoms. And those are things like slow stream. That's usually not that big of a deal for men. Sure, it's not like it used to be when I was in my teens, but it's not a problem. Okay, but if slowing of the stream turns into straining or challenges with feeling like you can empty your bladder, or on the worst extreme, urinary retention, where you can't go at all, that's a real emergency.
And all of these sound like they can add up to sincere quality of life issues.
Right. I like the analogy of if you wear glasses, you'll understand this, or maybe if you're driving in a car and you have a dirty windshield, or if your glasses are smudged, you can see fine. You may not even realize. But if then you take your glasses off and clean them, you realize, oh my goodness, I really couldn't see very well. So that's kind of how it creeps up on you with men too. And they probably suffer for a lot longer than they need to.
So it's a slow progression, but ultimately there is help, right?
Yeah. Oh, there's all sorts of help.
Let's talk about
and
that,
it doesn't
yeah.
have to be extreme. There's a number of different medications we use to relax the prostate, to slow down the growth or even shrink the size over time with medications. And then similarly, there are a few different classes of medicines that can dampen the irritation, overactive feelings in your bladder too. And so with a combination of medications, sometimes we can achieve a great success and a satisfaction that is all that's needed. Sometimes the medicines aren't good enough, or men become resistant or what we call refractory to the medicines that might have worked at first. So beyond that, there are interventions, and all of these interventions are minimally invasive in various ways. We can, with telescopic instruments and things, and lasers and energy, open things up inside, let's put it that way, so that you can then reestablish a kind of a really good, satisfying flow and avoid further problems or damage to your bladder.
It sounds like this is something where the earlier you seek intervention, the less intervention you need.
Probably.
Okay, so see your doctor at the first sign of...
If you notice these symptoms are happening, don't suffer in silence. One thing I would say is if you're getting up too much at night, there are a lot of reasons that could be happening. Having a big prostate is one of them, one of the common ones in men. But all sorts of things affect our sleep. Sometimes it has a lot to do with what you're eating or drinking in the evening. Common culprits of bladder irritants and diuretics are caffeine. So some people feel like, oh, I drink coffee at night all the time. It doesn't affect me. Well, it's a chemical response. Caffeine makes you have to urinate more. It creates more urine in your body, and it affects your sleep cycle. So you might fall asleep just fine, but you'll wake up just fine too and have to go to the bathroom more often. Same thing with alcohol. And so that's a lifestyle choice. Nothing against enjoying an alcoholic beverage at night, but it may be making you get up at night. It shortens your sleep cycle, so people feel like, oh, I'm fine. Alcohol, it helps me sleep, actually. I have a drink, a glass of red wine at night or a scotch.
Helps me get to bed, sort of.
Helps me.
Thought, yeah.
And maybe that's true, but it shortens your sleep cycle, so you're going to wake up sooner in the middle of the night, and it's a diuretic. So there's a number of things like that are contributors to getting up at night. And we go through all of that. If you come in and you start talking to us about it, we can help you. And if prostate is one of the problems, we can help with that.
That's a great segue into urinary concerns in men. It's not just dealing with an enlarged prostate. There's other things that can happen as you age.
Yeah, just like I was saying, all of these factors that contribute to it, your diet, your lifestyle. The other thing that I'll tell patients and point out is how the pelvis it only has so much space. It's a narrow space. It doesn't matter how big your body is, your pelvis is a bony structure. And that's a limited space that competes with a lot of organs and structures in your body. Your bladder, but your bowels as well. And so whatever you're eating, whatever your GI situation is going to affect that. So it's sometimes very helpful to think about it, to pay attention to what you eat, to your daily habits, let's put it that way, that can be affecting having to get up at night. Other medical problems affect the bladder, like diabetes, like other neurologic issues, and sleep apnea. That's kind of a common hidden culprit. A lot of people have sleep apnea and don't realize it, and that's a huge problem for your sleeping, obviously, but sleep apnea itself makes you have to go to the bathroom, or it generates more urine through the receptor responses in your body.
Okay,
Believe it or not.
break that one down for me. Yeah. I have never correlated that.
Right. It's a little bit of a complex cascade chemically inside, but the pressures created by sleep apnea on your vascular system then lead to a chemical that creates more urine. So not only it's just like the alcohol or the caffeine, it's one of those things that is waking you up and also making you create more urine at night. So getting evaluated for sleep apnea is something that we recommend to a lot of men when they admit that, maybe I snore or maybe I wake up, I'm not sure, and then they go get evaluated, and And if that's discovered, then that's a treatable problem that usually fixes everything.
Very treatable. Yeah, yeah. All right, and let's talk a little bit more about the prostate. And when it comes to prostate cancer, that's a big one that men start to think about as they age as well.
Yeah. Well, it's a good segue because the urinary symptoms from prostate enlargement are typically what drive men to the doctor or to be referred by their primary care doctor, thinking that maybe that has something to do with cancer and being concerned about cancer, because prostate cancer is the most common cancer in men. And if you live long enough, you may get prostate cancer. But it turns out that the symptoms really have nothing to do with prostate cancer. Prostate cancer is a silent disease. It's a cellular change, a mutation that happens in the cells that doesn't cause symptoms. It's just so common that it's worth getting screened for. And screening has been controversial because the only screening test that we had, which was discovered in the 1980s, is a blood test called PSA. It stands for prostate-specific antigen, which just means that it's based on a protein that's produced in the prostate. So there's no other place in a man's body that a PSA could be produced. And so when we look for it in the blood, it's coming from the prostate. But it's not very specific. It's not an accurate screening test because it isn't only elevated from prostate cancer. More commonly, it's elevated from prostate enlargement, which is extremely common, as we've just said. So that's why it's not a great screening test, because an elevated PSA is more likely to be because you have an enlarged prostate than it is from cancer. And the trick is to try to tease that out and differentiate it and figure out, okay, you have an elevated PSA. Do you have prostate cancer? Do you need further workup? Should we do something invasive like a biopsy, which has a few risks associated with it, or not? And that's where some of the controversies over the years have come to play. It's a little bit of a shame because it's not the greatest screening test, but it can be very helpful to find prostate cancer early in men. And there have been big national and international organizations that have come out against prostate cancer screening in years past, and that's done a bit of a disservice. Yes, there has been overdiagnosis, which can lead to overtreatment, and that's where these organizations have stepped in and said, maybe we shouldn't be doing this. But what it's happened is that studies now are showing that because of some of these recommendations against prostate cancer screening, men are now presenting with more advanced, more aggressive prostate cancer and worse outcomes. And now we've seen that catching up now. It's also a bit ironic because we don't rely on PSA, blood test screening, for prostate cancer anymore. So all of the controversies, I would say, of the past are somewhat moot if you go to a center of excellence, if they understand what to do now, which is to use really high-quality imaging. So if there's some concern about the PSA, now we go to imaging to see if there's actually something to worry about in the prostate. And only in that situation do we go further. And that approach has been shown to be highly accurate and avoid overdiagnosis.
As far as data goes, do you know what percentage of men in their lifetime face the risk of developing prostate cancer?
Yeah, and somewhere around 1 in 7 men currently, yeah. So it's pretty common. Worldwide, there's over 1 million men diagnosed every year with prostate cancer. Yeah.
And then, so let's talk about the treatment, if it does come back positive.
Yeah. So again, it matters where you're seen. Some men are still in the community, maybe even getting a biopsy right off the bat, which is probably inappropriate now. You want to get an MRI. You want a high-quality prostate protocol MRI, which is not going to be the same everywhere you go. There's actually a difference in MRI scanners. There's different quality in the magnets, let's say. There's different protocols, and so even if you're being scanned on a good machine, if it doesn't have a specific prostate cancer protocol, it may not capture all the right images, etc. And so you need to have your imaging done at a good place. Then you need to be seeing somebody who knows what to do with that information, and kind of the gold standard now would be image-guided, targeted prostate biopsies using different techniques. We do something that's somewhat innovative and rare, called transperineal fusion biopsies, which is not offered at very many places. The benefits of that are not only the sort of precision diagnostic accuracy, but also the safety. It's not associated with any risk of infection, for example, like some of the more common or traditional approaches. And then, after all of that is said and done, the sooner you're diagnosed with prostate cancer, in general, will often mean that it's not widely spread around your prostate. And so if you are found to have cancer while it's still within a focus in your prostate that can be seen on imaging and confirmed on biopsy, then you have all sorts of newer options available to you that may be better than some of the more traditional or radical treatments. Not to say that those aren't going to be important and necessary for a lot of men still, and we're not going to be moving away from some of the more extreme or what we call radical treatments. But we do have a lot of innovative new focal treatments that, if you're diagnosed early enough, you may likely be a candidate for.
Okay. All right. And so the screening, because there are no symptoms with prostate cancer, is recommended starting at what age and how frequently?
Great question. Most major organizations that talk about screening recommend starting in your 50s and then stopping somewhere around the age of 70 or 75, depending on which organization you talk to. But age is just a number, so it's really about your life expectancy. The interesting thing about prostate cancer is that it's a very slow-growing cancer. Even with the highest risk cancer, it's still fairly slow-growing, and certainly for the earlier stages. So if you're detected with prostate cancer early based on starting with a blood test and then an MRI, you may have 20 years before it will really be a problem if you do nothing. And nobody's going to do nothing if they know they have it, but knowing that kind of slow timeline, it makes the point that if your life expectancy isn't that long, then maybe it doesn't matter. Maybe you don't have to be screened or aggressively treated. And so we're not going looking for prostate cancer in somebody who's 80 years old and hasn't had it yet, because it's not going to be a problem for them, even if they have it or get it. But in a 50-year-old man who's perfectly healthy, he probably doesn't want to die of prostate cancer when he's 70 years old. And so that's what's important about screening, not only the age range, and that's why it's defined within a certain age range, but also the health status and life expectancy.
That individual.
So, right. So if you're in your 50s, but you have serious cardiac issues or liver disease, and your life may be limited, then no need to worry about prostate cancer probably. There's other things to worry about. Now, there are risk factors for prostate cancer, and so if you have a family history, if your father or uncle or brother, on your male side, had prostate cancer, then you're at risk, and that increases your risk of being diagnosed exponentially. And also, we know that African Americans are at higher risk for getting prostate cancer earlier. So in those cases, some organizations recommend starting screening in your 40s if you have a risk factor. And depending on what your PSA is in your 40s, whether you need to continue to be screened every year after that, or you can maybe wait again until you're 50 at that point.
Okay. Well, and that initial screen, again, is just the blood workup.
Just a blood test.
And if you find the antigens, then
right.
You have to go into imaging.
Right. Another common misconception is this PSA cutoff. If you've ever had a PSA or if you read anything about it, you'll see that the lab defines an abnormal PSA as over 4. And that was just a convention decided upon when PSA as a blood test and as a protein was discovered and clinically introduced in the 1980s. They just picked 4. It doesn't mean that it's not like a pregnancy test that's either positive or negative. There's a range, and a man can have prostate cancer at any level of PSA. It's just that the higher it gets, the more likely. And so, for example, we know a PSA of 2.5 will confer the same amount of risk as a PSA of 4. But we just use 4 because that's how it was set up long ago. The average PSA in a man in his 50s is less than 1. So we use that actually as a determination of how concerned we should be. And so if you have your PSA checked in your 40s or in your 50s for the first time, and it's less than 1, you're in great shape. You probably don't have any lifetime risk of significant prostate cancer, and you certainly don't need to be screened nearly as often as a man whose PSA is over 1 at that point.
So for the generally healthy, average 50-year-old adult out there, if they get screened at 50 years old and it comes back as a normal range, like less than 1, when should they go back for a second screening?
I don't have a great answer to that because there's no guidelines around that specific question. Guidelines are just introduced for populations, and the recommendations are, okay, let's say you don't have risk factors and you get your PSA checked in your 50s and it's not concerning, then you probably don't need to have it checked more than every 2 years. There was a European study that suggested every 4 years was fine. And there's no real guidelines around, well, what if it's just less than that average, which we also know is probably very safe. But it suggests that you don't need to be screened all that often. So I don't have a perfect number every 5 years, every 10 years, but you kind of won the lottery if your PSA is less than 1, but you probably should have it checked again at some point. There's just no rush.
Right. Sounds like a conversation between you and your PCP.
Absolutely.
Okay.
Yeah.
Okay. All right, great. So let's talk about testosterone testing. Since we're talking about testing, the importance of testosterone. What does testosterone do for the male body, and then why would you test it?
Testosterone does all sorts of things in a man's body. It's involved in development of male characteristics and physical features. It's involved in sexual activity, function, and interest. It's involved in muscle mass. It affects red blood cell. It affects mood and cognition and cardiovascular health, and so it's vastly important in a man. And it declines naturally with age, and so there aren't clear guidelines on whether, because of that, and based on certain risk factors of your health status, should you be on replacement, and that tends to be just a choice that a man makes with his doctor, with some caveats. And so one of the other things that testosterone does is it drives prostate cancer growth. It doesn't cause prostate cancer, but it drives growth. And so if you have prostate cancer, you don't want to be taking more testosterone because that's adding fuel to the fire. So any man who is considering replacement of testosterone needs to be screened for prostate cancer very carefully first. That's one thing I would mention.
Yeah, that definitely sounds important considering the lengths you have to go to test for prostate cancer.
Yeah.
Okay, and so testing for testosterone, what type of test
That's
is
just
that?
a blood test.
Simple blood test.
Yeah.
And then adding testosterone to your system if it comes back low is, what does that look like?
A lot of men seek out testosterone replacement because they want to feel vital and young. They think it's going to help them with sexual function. But some of that replacement would be inappropriate. So I think guidelines suggest that you have to have a constellation of symptoms as well from low testosterone. So not only should you be having issues with sexual function or drive, but also other things like fatigue and mood change, sleep disturbance, muscle loss. So the other things that are important to testosterone you should have, in which case then it would be perfectly appropriate to get replacement. Probably the majority of men on replacement don't have all those other things and are just doing it to feel a lot more energy and a lot more sex drive. And that's their choice, but as long as they're being monitored appropriately. The treatment is simply medical. There's a number of different ways to give that via injections or gels.
Oh.
Yeah.
Okay, and is it prescription-based?
Prescription-based, and you have to be monitored. You have to have your labs followed, to see where the levels are. And once you're at an appropriate level, see how that's maintained.
Is there a general age by which you say, okay, your testosterone might start be declining now?
Oh, the testosterone starts to decline, in the middle age, even the 40s or 50s for sure, it starts to decline.
Okay. Alrighty. And then let's talk about Biopsies, when are they recommended, and what do you use biopsies for?
Right. Like we talked about a little bit, if there's concern for prostate cancer based on usually initially with a PSA and then a good quality MRI, we discuss biopsy with a patient. And depending on where you go, who you see, you may be offered an awake in the clinic biopsy with some local anesthesia, which is a perfectly good way to do it, but it may not be the most advanced way these days. Or you may be offered an image-guided biopsy, which we call fusion biopsy, and that can be done in a traditional way or in a really fancy way like I mentioned we do with transperineal approach. So depending on how it's being done, it may be done awake as well, or with some sedation, or with general anesthesia, which is how we do it. One of the ideas is that because the image is being fused in real time with MRI, you can't move around or it disrupts the location of things. Mm-hmm. And so you have to be asleep, you can't be moving, and that's nice for the patient too, so you don't have to be awake for that.
Yeah, and so that is specific for prostate cancer testing.
Absolutely, yeah. That's what a prostate biopsy is done for, exclusively to rule in or out prostate cancer.
Okay. And are there any other current treatments that are just coming onto market or that are good for men's health in general as they age?
So for prostate enlargement, there's a history of innovation there. In fact, urologists were the first to introduce endoscopy with telescopes and doing treatment for that disease through a telescope and a candle back in the day. Now we use lights. So we've always been innovators in that field, and that continues with BPH treatments now, with lasers, with devices that can be placed to open things up in there. And so it might be worth your time to get some extra opinions or to do some research online to see who's offering some of these newer things that sound exciting. And same for prostate cancer. You know, like I mentioned, these focal therapies, there's all sorts of innovations. We pioneered a brand new technology that is not commercially available right now, and we'll see if that becomes available using gold nanoparticles. We're currently doing an FDA-approved treatment using electrical field generation, which is known as IRE and commercially known as nanoknife. The nice things about some of these focal treatments is that you can accurately get rid of the cancer while sparing all of the unwanted quality of life side effects. And one of the reasons that some men avoid getting diagnosed or following up for prostate cancer is because they've heard that the radical treatments can affect quality of life issues like urinary function, incontinence, and loss of sexual function, which scares people away. But these new treatments can avoid a lot of that.
Yeah, that sounds great. It sounds like the prostate is the biggest culprit to men in general as they age, right?
Yeah.
But there's also testicular cancer, and that actually is more common in men when they're younger.
That's right. That's right. Testicular cancer is not nearly as common as prostate cancer. And the good news is that it is one of the most curable cancers. And so you have to find it, and that's often done because a man will feel something funny there in the testicle and maybe keep an eye on it, and then it doesn't go away, so they seek out care with their doctor and eventually end up with a urologist. There are recommendations around sort of self-exam, but I don't think a lot of guys probably do that. But fortunately, it's picked up in time often. Like mostly it's picked up before it has spread around the body. But even in those cases, even when it has spread, it's very curable. We can't cure everybody with testicular cancer, so we do prefer it to be detected early. Mm-hmm. But because it happens in younger men between 20 to 35, let's say, they're going to be younger, they're going to be healthy, they're going to be able to get through the treatments, be those surgery or chemotherapy or a combination of those things. And that's one of the other reasons why cure rate is so high. It's also a very chemosensitive cancer. So when we talk about cancers, chemosensitivity means that they respond really well to the chemotherapy.
Okay. So it sounds like screening is like the first course of prevention, right?
Yeah, I guess the take-home message there is that if you're a young guy and you feel something funny, don't be afraid to go feeling for it. And if you do feel something funny, get it checked out.
Yeah. Yeah. Always speak with your doctor, right?
Yeah.
What is your one take-home message to men of all ages about their health?
Yeah, don't be so stoic. Pay attention to your health. Don't ignore these symptoms. It's important to take care of yourself. I think that men sometimes do that really well with working out or exercise or paying attention to their diet, or at least thinking about those things. But other symptoms that start to become more and more noticeable as you get older can also affect your quality of life, your sleep, and it's important not to ignore that.
Yeah, there are great urologists at UT Physicians like Dr. Steven Canfield and his team who are here to take men's health seriously and to see them through whatever they may face. Thank you so much, Dr. Canfield, for joining us. And thank you for tuning in for our very first episode of Real Talk in Medicine. Again, this is a production of UT Physicians.